When we compare the drugs available, what we consider for a third-line setting, number one, of course, EGF-receptor antibody. I think they have the most solid data in a sense, as single agent or in combination with chemotherapy based on prior studies. And we've refined the patient population that can benefit RAS, BRAF wild-type tumors, right-sided tumors. So I believe these are standard of care. This is a standard of care using panitumumab, cetuximab, either single agent or in combination with irinotecan, for instance. They have pretty good efficacy. And actually, we can expect to see some tumor shrinkage when we select the patient right again, right-sided, left-sided RAS, RAF, wild-type tumors. So these are standard of care. Regorafenib and TAS-102 are newer drugs. They are not restricted by any sidedness or molecular profile. So we have no data that patients only benefit when they have RAS wild-type or BRAF wild-type in a later line setting. The correct study, which was a pivotal study for regorafenib, randomized patients in a third, fourth line settings after failure of standard therapy to 2-to-1 to regorafenib versus placebo, showed an improvement in overall survival with a hazard ratio of 0.77, which means a 23% reduction of death events on the study. It was mainly related to disease control rates. Some patients had prolonged disease control. The main issue with regorafenib was the side effect profile, at least at the dosing schedule that was used, 160 milligrams initially, which we later kind of addressed in a randomized comparison. But it's definitely showed efficacy in a single agent in a later line setting. TAS-102 was developed very similarly about 2 years later after regorafenib, 2-to-1 randomization, international study against placebo. 100 patients of these 500 patients actually pre-treated with regorafenib, and there was no difference in outcome for TAS-102 whether patients had received regorafenib or not, which I think is an interesting piece of information. Overall survival endpoint was reached with a hazard ratio of 0.68, so a 32% reduction of death events on the study. The progression-free survival curves of TAS-102 and regorafenib are completely overlapping. You can do a PowerPoint experiment, really projecting them on top of each other, and you wouldn't know which line is which. So we have very similar data, disease control in about 45 to 50% of patients, really no objective responses. And patients normally tolerate subjectively TAS-102 better than regorafenib because there are fewer subjective side effects. TAS-102 side effect is mainly neutropenia, which at this point in time, the coronavirus epidemic, is something we actually don't like, so the actual recommendations in terms of sequencing from regorafenib and TAS-102, which was one of the questions, to use regorafenib first and reserve TAS-102 for later time point. Regorafenib is active as a treatment option in the later line setting in colorectal cancer, and as a cytostatic agent, we want to keep patients on therapy as long as possible because that is really how this drug will be most active, by prolonged exposure. Now, the problem with regorafenib itself, especially in a high dose when it was used with 160 milligrams per day, like in the pivotal registration study, is that a lot of patients will encounter side effects, subjective side effects like fatigue, hand-foot skin reaction, which is an inflammatory response to the drug on their palms and feet, sometimes blister formation. And these side effects come early on in the treatment of these patients. So we actually see these side effects come within the first 2 weeks of therapy, which is different, for instance, than the hand-foot syndrome with capecitabine, which comes over time with more delayed effect. So when we learned how to use regorafenib, one of the important points to recognize was side effects come early. And this is the first 2 weeks are really the critical time point to monitor side effects, make dose adjustments, really get patients used to this drug, because we know the longer they get treated, the better they tolerate it. And so that's an interesting phenomenon. So that's why we ran a study, actually randomized comparison, trying to optimize the regorafenib dosing administration by comparing standard dose, 160 milligrams, which is 4 pills a day, 3 weeks on, 1 week off, to starting with half the dose, 80 milligrams, 2 pills for the first week per day, then getting a toxicity assessment from patients, and then if they tolerate 80 milligrams, go to 120 milligrams per day for week 2, and then really try to go 160 milligrams, the so-called standard dose, in week 3, and then patients have a week break, come back to cycle 2, and then you can ask them, which dose level did you really tolerate? And this is the dose level where patients will continue. So this randomized comparison over 100 patients actually compared the escalating dosing strategy to standard starting dose 160 milligram. And now when you run a study like that, you need to have the right endpoint, because safety toxicity is only one aspect of that. You also want to make sure that you're not harming patients in terms of reducing efficacy by lowering the starting dose. So the endpoint we chose was, how many patients will go cycle number 3, because after 2 cycles, 8 weeks, we got a scan, and patients would only continue to cycle 3 if they, number 1, tolerated the treatment, number 2, had at least stable disease on a scan. So that was the primary endpoint. And yes, the study met its primary endpoint. Actually, quite surprisingly, there was about a 20% difference between patients who kind of continued to start it on 160 milligram compared to patients who escalated the dose, who were able eventually to continue treatment into the 3rd cycle. And there was a trend, not statistically, not powered for that, toward improved survival with a lower starting dose, presumably because patients could stay on therapy longer and their quality of life will remain stable, whereas for patients who started with a higher dose, there was a dip in quality of life in all our parameters in week 2. So I believe the standard of care right now in colorectal cancer, dosing regorafenib is starting with half the all standard dose, 80 milligrams, ramping it up slowly. And this is actually embraced by NCCN guidelines and has really changed the way how we perceive regorafenib. It's turned from a perceived toxic, not very effective agent into an agent that can be used in a community practice, even physicians who don't have a lot of experience, with managing these side effects. And I believe it really gave regorafenib a second chance.